Bridget Lalonde and Alice Reiner from START Corporation and No AIDS assist us with this webinar, and we're really pleased that we could actually do a training by webinar. This is new for us to do with you all, and if this works, we'll, hopefully can use it in the future for other information sessions that you might be interested in. Today we're beginning with what I consider to be one of the most basic, absolute necessities, basic management tool that you need for the new business model that you're launching. And before I get into the slides themselves, just three quick things. One is, that you're not necessarily exactly flipping a switch to a new business, but you're pretty close to just flipping a switch to new business. You need new tools, new techniques, new way of thinking about how you operate your business. And you've been very fortunate to, all during this startup period, the 7 years we've been in startup in this program, you've been very fortunate to be on grant funding, which typically only lasts 2 or 3 years with a new program. And so in a way that may have worked against us a little bit, because even though we went to program standards for a few years ago, and one of the things folks did was to really be conscious of the staffing requirements that you need to meet, we didn't shift some of the other requirements that you need to meet now. Like we talked about things like staff-to-client ratios. Now it's really about billable hours. We used to talk about staff-to-supervisor ratios, and even though we think you should keep those, it's really, again, about supervisors being as talented, skilled, and knowledgeable as possible to guide you through this new endeavors that you're undertaking, but also highly qualified staff. So I think you need three things to be successful. One, basic management tools that you use over and over and over again consistently. Two, good, well-trained staff. And three, good, well-trained supervisors. Because a lot of things are going to be thrown at you, and if you have those three things in mind, good basic management approach, use tools, good quality trained staff, good supervisors, then I think you can make the kind of switch that will be necessary. So why don't we go to the first slide. Amy, if you can, there we go. So we're going to talk today about tracking. We're actually going to be talking about managing and tracking, because tracking is really a part of managing. It's really what you do with the tracking. Make sure that you're tracking the best stuff you can consistently, daily, if you need to. That's part of managing. We need somebody on mute, I think. So if we can get everybody on mute. Okay. So managing and keeping track of critical data is basically essential. You've got to track benefits, entitlements, services, eligibility, all of those things. And if you get behind or lose out on those things, bad things happen, and they happen pretty quickly. So it's very important. We're going to talk about two different systems today to collect and update data. And there's really, I don't want to say there's no wrong system. There are different approaches, and we're going to hear two different approaches. But it's got to be organized, functional, and relatively easy to use, because remember, it's got to be used by everybody who works on your team. So let's go to the next slide. So why track? You've got to be able to make sure that you're tracking so people can actually get into housing, because your tracking you may lose track of people, no pun intended, and people might lose housing simply because the tracking and getting all of the different eligibilities reestablished on an annual basis, you might get behind, and lo and behold, somebody could lose their housing. Obviously, you want to be paid and in a timely way, and there are always kinks in new managed care systems. They last for a couple of years. You've been no exception. It's widely noted. Everybody knows that. There's been problems. But at some point in the near future, those problems will get worked out because they're already getting worked out. And when they do, most of the issues related to your payment are going to be yours, not somebody else's. So right now you could say, well, somebody else didn't do something, but it might have been partly you and might have been partly them. It won't be too long now where it's going to be mostly you. So timely, accurate data collection, tracking, and reporting is, it really is, we want to stay in business. I don't know how to say it anymore. As you guys know, I don't pull any punches, so I'm being really concrete with what we're saying today. So it's the foundation also to be able to monitor your performance, which again is extremely important going forward. Your referrals and the number of referrals that you get is going to be based on your performance, and it's better for you to monitor it and know what your issues are, because those will be noticeable to your funders. And then supervisors. It's really, really a great, tracking data is, you can cut right to the chase if you're a supervisor for your, for the work that you're doing with individuals. And then I would suggest, and I know some of you do this already, your own self-evaluation, your own performance reviews. Okay, Amy, so we're going to the next one. What to track? We're going to talk a lot about that today. There are a number of data elements that the PSH program wants you to keep track of. And then there are some things that you may want to keep track of so you can, again, manage. So you'll be asked to track some things, and then you may want to track some things. This last line here is Patty's, and it's a good one to remember. Not all data is created equally. You don't want to track everything. You want to track what's essential. So that's, it's really being smart about it. Okay, so next slide. What to track. This is a nice chart that you can use. It's a take-home for you. And you could, I would suggest that you keep this kind of what to track list, and that you add or subtract from this when the program changes, just so you can keep, again, no pun intended, keep track of what you need to track. Demographic information, important numbers, disability, dates, assessments, approved benefits. I don't need to read them all. One thing that I know that Alice in particular is going to talk about is how she can pull down reports for each and every one of these. For example, you may want to run a monthly recertification report, on housing, or a recertification report on Medicaid and whatever, so that you're out in front of your game. A locus, a 1959 recertification date. You're going to want to track your critical incidents for performance, your own performance. Are we seeing any spikes of any type? Is that related to our client mix, or is that related to our really not keeping up? Obviously the housing voucher type, and pretty soon you'll add PRA to that. So I could go through this whole entire list, but we want to turn it over to our guest speakers today, so I'm going to move on. But you can see the listing here and how you would want to keep that. Okay? Number of different ways to collect and track. Creating a system that works for your program. Some tracking systems are more expensive, and if you're in an agency has multiple programs, you might be able to afford one of those. But there are a number of systems on the market today at all different kinds of price ranges. And you'll hear a little bit about that today, because Bridget's going to talk about a system that fits the size of their organization and what they're trying to do. And then Alice is going to talk about a system that is agency-wide for NOAA AIDS. And I think at this point, Amy, you want to hit again? Okay. So what we're going to do with our guest speakers, Patty's going to facilitate this discussion, but we're really going to hear from Bridget and Alice. What considerations did they take when creating and choosing a system? How they manage their system. In other words, the other thing about a system, whatever you put together, if somebody's got to manage it, somebody's got to be responsible for it, because if it's left undone, it's sort of like when we ask you for the rosters. If you're only collecting it when we ask you to collect it rather than collecting it routinely, then you've got to rush around and put it together. And in the past, your system, whatever you collected and handed in, it really didn't make a material difference to whether or not you were paid. Let me say this again. In the past, your managing your information did not have relevance to your getting paid. Okay? Come October, it is totally relevant. It is the difference between your being successful and not, along with quality staff, quality supervisors. Lessons learned. Not all systems are equal, not all approaches are equal, and if you're just starting to use this for the first time, you're going to have some, bumps along the way. So what are the lessons learned from your esteemed colleagues? And any advice going forward? So, Patty, I think I turn this back to you to get us started.
Yeah, so we're going to start with Bridget from Start Corporation. She's going to talk about the system that she designed and then how they're using it internally. And Bridget, I think Amy is turning control over to you.
Yes.
And you can just walk folks through the system and, highlight some of the points that Marty was talking about and how you use your system and what works well, lessons learned, and all of that.
Okay, awesome. Let me just say, Brooke Guidry's the one who actually designed this, but I'll take y'all from the beginning, where we were, to where we are actually at now and where we hope to go. Can everybody see this table?
Yeah, they're on mute, Bridget. So.
All right.
Yeah.
Okay, so
yes.
As you all know, as a team leader, it's very important to always track the caseworker and who's on their caseload and things like that. So in the beginning, started off with a very basic chart with all, at a particular time, pertinent information. And then we were asked to do the roster. So then manually what I was doing, going back and forth, adding the important information like the person's disability, well, Medicaid, disability, their payer source, IA information, and things like that. But I started adding columns to here based on what was required for our rosters. And also another feature here, another thing that happens is it started to allow the worker, because they each have their caseload, to be able to better understand not only who's on their caseload and when hurricane plans are due or charts or completed audit, but it better helped the worker to understand and see where they were with the client's Medicaid and actually the payer source and IAs and things like that. So you can see that in the beginning I started one way, but because of the roster and the things that we needed to do for the program and where it's going, I started just entering in the other stuff. Just on my roster, just so you all can see this, this way that I did it, what I wanted to do is I wanted to capture as a provider and now going, from the grant funded into the business, I thought it was important to break all of the different waiver types down. So if you can look, you'll see 1915I, OAAS, DD, Ryan White, dual, this sheet or this tab is for people who may have a long-term care waiver as well as B1915I. And the reason why that's so important to me is because a lot of times when people come out of the nursing home, they may come out with a waiver, but that waiver may expire. And when we're talking about moving from grant-funded into a business, I need to know if a person's waiver is going to expire, because I need to make sure that there is a payer source in place. So some of our people do have 1915 Is in addition to the OAAF and DD. I put a tab in there for veterans just because at one time we were told that people who were veterans should be working towards getting some housing from some type of veteran program. Although it's very important to me to watch these columns, I really focused a lot on CDBG column. The reason for this is my goal was to get as many people in a very ethical way off of this spreadsheet and place them or someone in the household into one of these differing waiver types. And so what we've done is we've just examined all households, and of course you can't avoid having people in this column. But this actually allowed me the ability to see exactly what we were working with. All right, so here's where we went with this roster, because of course this is very lengthy, it's hard to read, and it's hard to keep track. But I think the main thing is it helped us to really organize, and of course through different calls, where we were, what we needed, and then of course now where we're going and where we're headed. What we did is me and Laura and Casey and Brooke Guidry, who is our IT person that y'all don't really talk too much on the calls, we sat down and we discussed the different things that we needed for this program and to make the business successful. Because I can honestly say that the last thing we want to lose is the quality of services that we provide. And it all kind of started not really with the roster. The database started because of the independent assessment. We all are assessors, and what we were finding is that the assessments took a pretty decent time, and we want to make sure, just like with our direct support staff who's going out hitting the ground working, we want them to be as definitely effective as we hope we've always been, but we want them to be as efficient, because time management will be one of the most important things. In addition to tracking, of course, but time management is important. So let me just kind of show you what this database can do when we're talking about things that were required for tracking, and then I'll just kind of explain to you the independent assessment and how all of that plays out. But as you look under on this first tab, you see I put Michelle Brown in as a client, but what we'll do is we know we have to track services as an agency because that's what we are. So we look at the refer dates, what program they're assigned to. It's connected to all our differing offices. We can track support worker. Remember this thing that it used to take me a long time to manually put in? Well, now it's there. We do different plans and things like that. But it also okay, well, wait, we'll go back to the waivers. So then we can put in a person's Medicaid number, their Medicare information, 1915I, their beginning date when it expires, and then down here what we've done is added the different waiver types, even including CDBG. And this thing, by the way, is very easy for Brooke to make any corrections to or additions. So this gives us all the different waiver types. The reason that we need to make sure that we're looking at these things is because, like I mentioned at the beginning of the presentation, that if somebody's in that nursing home and they're coming out with maybe, OAAF services, I need to make sure that the workers are having that conversation, is this a long-term waiver, or after there is an improvement, is this particular payer source going to stop? So we really need to track that. We, of course, will do our, at this time, we're going to use clinical advisor. We've incorporated primary and secondary for our provider status, because if you remember when submitting your logs in clinical advisor, they had originally told us that on the log we needed to let everybody know at Magellan if we were the secondary provider. We talk about, okay, so now I'll tell you a little bit about the housing. Marty had told us before that it's very important to track your housing information as well, because this is your services. And so what Laura and Casey and I did is we explained to Brooke all about this program and the different things that we need to track. We need to track their leases. We need to know when people sign leases. We need to know when leases expire. We need to know who's in what program. Right now, you know, of course, we send all of our research and stuff to Quadell, but I think we need to take this approach to make sure that everything is done on time and as easy as possible. So we'll key in a recertification date, transfer approval date. When somebody gets approved for a transfer, you put that transfer in there and it'll generate on a list. Right now, just so you know, we are still in the process of working on this, because you can see that on the front end, all of the data is actually put in. What we are going to do is be able to, and Alice will tell you how she does this, but we'll be able to run a report that'll say, give me, you know, the T number with every client, or if I want to know about John's caseload, I can punch it in and see, and it can calculate a number. If I want to pull in January for 60 days of whose 1915Is are going to expire, I can do that. If I need to see, if I have a unit that's popping available and I need to see if there were any transfers approved prior to looking at that selected waiting list, I need to just go ahead and pull that report. So we're going there with all of this. But as I mentioned earlier, the database was originally designed because of the assessment. The assessment took us a while, and so Brooke came up with this database, and we just added all these other things in thereafter. But as you can see, what we're doing, you come in, you add a client. So I added Michelle. And what this database can do, because remember, we want to save as much time as we can so we can provide some really effective services. You just come in and you type in all of the stuff. This is the actual independent assessment. It just has checkoff boxes. You enter some information. If you go to the drug tab, you can look, you can tackle everything here. Medical conditions, when you check any of these boxes, what it's going to eventually do, I made the suggestion to Brooke yesterday, it's going to go ahead and in the diagnosis tab on your general medical conditions, it's just going to pull up what the person's medical condition is. Because let's see, Meds Online, it'll pull up a list of all the different medications that a person may be on. Of course, you get the idea. Legal, it just is a fill-in. All right, I want to show you this. Mental status exam, of course, the risk, diagnosis, all the different things that are at the bottom, and then, of course, the locus. What it'll do is it'll just do a drop-down box and it'll show you everything. One thing that we thought of is, because this is online like this, is it catering to each individual's needs. And we've kind of talked back and forth about that, wanting to make sure we meet everybody where they are, and it's not like a cookie-cutter approach. So Brooke made sure that, of course, for chief complaint, presenting problem, and things like that, you can include. He gave you a lot of room for other, to where you can make sure that it's you know, specific to the individual. So just to kind of take it a step further to show you exactly what this does, this independent assessment, once you choose 1915I packet, all of Michelle's information up here would tie into, of course, you might not see it now, but the cover sheet with all of her information. It would go into the lawn form with all my information, as well as her locus score and everything else. It's going to print the actual locus, freedom of choice, with all information tied in, because we want to save that time. This program that Brooke has created is also used in other programs, so anything can be added. Something else, just to show you to save some time, this independent assessment, we want to be ready when we go live October 9th, and they tell us you need to go ahead and submit your authorizations, we want to be ready because the authorization will be generated here based on what was put in during an assessment. And it's really slow right now. All right, so all of this will be here, all right? And then, you know, for authorizations or any time a person's authorization is expired, you always have to do the concurrent review with Magellan. And this is the concurrent review. You can print anything. Here's where we're going as an agency, besides just needing to be able to run reports. Brooke is working on, we're gathering information about what other forms, and we don't want to work too early on forms because we're not quite sure everything that's going to be required. But we want to go ahead and make sure any necessary forms are included in this database so that when we go ahead and enter Michelle's information up here, and psychiatrist and number, and I mean, I don't know if y'all find this, but what we've done is gotten a lot of feedback from the team. We find that a lot of documentation is repetitive. We want to be able to take any of this information and it to tie into the forms. And that way, when we need a form, we can cater it specifically to the individual and just press print, review it with them, and have them sign it. So that is really our database and where we, I guess, were and are going.
So Bridget, this is Patty. When you, and then we'll move to Alex next, but just real quickly, when you think about managing a permanent supportive housing program where you're balancing services and housing, and each of those components require certain data, just generally say how you think the way you're tracking and what you're tracking and how you're tracking really supports you to be efficient, effective in both that management capacity, but also then the service delivery.
I think one of the things I'll start with of course, the management. You know, our workers will be required to be out in the field to be able, I mean, it's a business. They have to make money in order for us to survive. So, you know, I will be able to see, you know, just from this database what's in, what's not in. And then as well, I think this whole process has really helped everybody understand everything a whole lot better. Services, like I've said before, I mean, it just gives you a way. I mean, I cannot express to everybody, and this was not yesterday. I mean, we've talked about this over and over, that this process has taken us, I mean, at least a year to even get here. And I think the main thing that our agency has done, and I can speak for, you know, us only, we have spent so much time on the phone with Magellan, you know, during calls, answering a lot of, I mean, asking a lot of questions. And this is really, the services, I think the fact that we can monitor stuff, I mean, right now I am manually, well, now they're entering everything in, but before I was manually, you know, on a spreadsheet putting January, February, March, and having to write down whose IAs were needed. And you would not believe, and we don't have a huge agency, but you wouldn't believe the amount of time that I spent doing stuff like this manually. And of course, I mean, a person can only do so much. You do all of this stuff manually track, and it takes away, something's got to give. So if I'm spending all my time doing this manually, even though, of course, I'm there for supervision and working with this team, I feel like this is the best way to go because the computer's going to generate, of course, you have to input the data. Wouldn't it be nice if, I don't know, we didn't, but somebody's got to put in this data, and then I can just run the report. It gives me more time because I need to make sure at this point, even though we've always audited charts, we've always checked for the quality of services, we need to now make sure that we're providing not only good services, but billable services. So I guess, I mean, that's just how I feel.
Yeah, that's great. Thank you very much. So we're going to, there'll be time for questions at the end, but we want to move on to Alice Rayner's system over at NOAID Task Force. Alice has a different strategy. And Alice, Amy is turning controls over to you, and you can explain your system and how you use it to monitor and manage your permanent supportive housing program.
Great. Well, so I would definitely echo everything that Bridget said. We started this process over a year ago, and it was kind of in an effort to move away from paper charts just generally, and it was part of a larger agency initiative to have better data collection, better management of the program. We looked at a lot of different programs. We intentionally did not go with an electronic health record system, and instead we went with something that's called Client Track, which is an HMIS-based system. But some of the reasons that we really liked it, one, it's web-based, so staff that's out in the field, if they need to look up information about a client, they can. If we have a hurricane, we have all this information on a client. We don't have to worry about trying to get access to the paper charts. And it's easily modifiable. So as I'm sure all of you guys know, we didn't always know at the beginning what we would need to be keeping track of in a year from now. So to have a system that we could modify in-house was very appealing. So I'll just go through it briefly. I put Marty in as a client. And on the left-hand side here is all the things that we can keep track of for a specific client. And we've just started kind of inputting and using its full capabilities. But on the dashboard, anytime you bring someone up, you have the name, the address, the date of birth, social security number, you know who their case manager is, you know what kind of enrollment they are, and you also can tell, we put in who's had a 1959 done and who's been approved through Magellan. And we can then run reports based on that and who's going to expire, so we can keep track of that. Another feature that I like about it is the document checklist, where we can scan and upload things. So when we're emailing Quadell or anything like that, it's all here, and we have copies of it. We can also put in, landlord phone numbers, so everybody doesn't have to keep their own list. Because that was the other thing that we found, is everybody has their own list of caseloads and contacts and all of that, so it's in one central place. We have the case manager, and if we have turnover, we can just inactivate this case manager, and we can see, especially if we've had more staff turnover, we can see how many different case managers have been working with this client over time. Family members, Marty and Patty's a family member there, but you can see who else is in the household, which helps for recertifications. And then there's a whole long list you can see here on the left of all of the things we can keep track of, a lot of which we haven't even started using yet, and I don't know that we will. But it does have a place for the insurance. So we can pull up and put in who has Medicaid, who has Medicare, and then their numbers and the start date. This status thing has also been very helpful because the clients go in and out of having active or inactive Medicaid, NOPI waivers, Medicare, all of that. So that's been very helpful. Let's see. We also have put in the crisis plans. So for people who, the evacuation and the emergency contact, all of that can be on this page, and we can run reports when DHH is asking for those and what people's plans are for evacuating. Services here. We can add, we have the 1915I stuff. We can also add in other services. So this is where we're going to keep track of who's going to be on the CDBG waiver, the other waivers, the locus score, as well as we could keep track of other hours and service units here if we chose. Depends on what we're going to do with clinical advisor. And then another thing that we're going to keep track of is the recertification dates, which you can do here and be able to run a report. And the incident report, which is another thing that you keep track of with hospitalizations and arrests and everything like that. So that's kind of the basics of the system. We started inputting. We actually ran the roster we turned into Magellan from this. But one of the things I really like about this system is the ability to run reports. So I'll show that to you guys. You can pick what fields you want, and then it drops down here, and then it dumps it into an Excel spreadsheet. Takes a minute. But you can get all this information, and you can run that per case manager, per the program, per a team, whatever you want to know. And it just really helps us to be able to manage the program. So that's all I have.
That's great, Alice. Thank you. And I think the point that you made about this system and its ability to run reports and the fact that it's web-based are sort of the selling features for a web-based system. Marty, any general comments you have on either or both of the systems before we open it up for questions?
No, I think a thank you to both the speakers. I think this is great, and you can see, obviously two different approaches, but the same material, the same kinds of flexibility, and really putting you in the driver's seat. So I think we should just go to questions.
So we'll open it up, either a question for Bridget or Alice about their systems that you might have, questions or comments or observations, or even sharing about the types of systems that you have. We have a couple minutes for questions. Do other people on the line have similar ways or systems to track their data? If you're muted, you might want to unmute. Crickets. Does that mean, so does that mean you guys are all like doing this amazing job tracking data? That's great. Hello?
Hello?
Hello? Hi.
You hear me?
Yep.
Yeah, this is Alternative Living. We are currently, our database is being created, so we're constantly having feedback with our IT provider. So basically, ours is pretty much along the same lines as the two that we've seen, but we just wanted to let you guys know that we are in the process of having that created.
So is your system going to be web-based like the system that Alice showed, or is it just going to be, or is it not going to be web-based, which was the system that Bridget was showing?
Yes, actually it'll be connected to our server so that it'll be able to be accessed from anywhere because you can dial into our server and we have the internet cards to do that, but it's not going to be web-based. We wanted to make sure that we could control the security of it here, which is why it's going to be on our server.
Yep, great. Yeah, I mean,
Hello?
Yep, go on.
Yeah, this is Richard G. with Baltimore, Maryland. Can we somehow get a copy of the PowerPoint or CD or email so we can?
Yes, we can do that.
Okay, thank you.
We'll give it to Michelle. Michelle, and you can send it out to the group?
Yes, that'll work.
Great, thank you.
So I have a question. This is Marty to Alice and Bridget. What's the feedback from your staff with these systems? What are you hearing from your staff?
They are pumped up.
Pumped up, okay.
Pumped up because, when we told them, of course, fee for service and the requirements and what they would need to meet, a budget or anything like that. I mean, Marty, you're talking about an agency of that honestly, we're in a small, well, I'm speaking for our area. In a small town, everybody knows START in this area, and we've pretty much provided, our workers have been doing this for years, and they've provided all these good services. And when we told them that there would be units issued, and that may not be able to see people as often as they're seeing them, and there was a lot of resistance with the model initially. So I think what me and Laura and Casey had to do is just kind of reassure people that this is, even though we're going to a business, we are going to try to do our best as management to incorporate some type of system to reduce the paperwork. And when you say reduce paperwork, support specialists' eyes just light up. It's like, okay, because I think I can tell you, speaking from myself, one of the things that I dislike the most about this actual position was the system that I showed, the first system that I showed you, where I had the caseworker spreadsheet and I manually went in. You know, I'll ask myself, you know, like, am I really supposed to be doing it? I felt like data entry, you know, just doing that, because I spent a lot of time calculating that kind of stuff. So when we mentioned a database, you know, some people at first were very intimidated, like, uh-oh, what if I don't know how to do this, this, or this? But when you tell people that it's going to reduce your time in doing paperwork, and also it's going to, the first thing, it's going to definitely improve the quality of your services, because with the allotted units that you're given, you're going to be able to provide those really, really good quality services. And then the other thing, I think it helps the staff to be able to see what I'm looking for. You know, when we first said roster to all of the staff members, it was like, oh my goodness, you asked people for their Medicaid numbers, and we were getting all of this 777 stuff, and people were just kind of giving you whatever. But throughout the whole process, every single person on our team, they really understand now why we need this. And if I feel like as a team leader, if I'm going to require people so many hours, and I'm going to have this expectation for them that you have to do this. Okay, you used to do it this way, but now I need you to do this to be able to stay open. They have to know why they're doing it. There's nothing worse than expecting something from someone and not knowing why they're doing it. So what this whole time has allowed us to do at START is really get each worker involved on this end. Even though they didn't sit on every call, we didn't tell them every single thing along the way. We still kept these main points open in discussion and team meetings and stuff. So overall, everybody is super excited.
Good. Great.
Alice, how about you?
I think the managers and the supervisors appreciate it because they're the ones that have spent a lot of time with the old Excel spreadsheet. I think the staff is coming along. I think they see the utility of it. You know, change is hard for a lot of people, and I think and some of them are really good with clients and not so good with technology. But one thing that I liked about Client Track is the interface is very user-friendly. So we really tried to make it as easy for people to use it as possible.
Yeah, I think, Alice, that's a great point that you raised, that, you know, many direct care staff are very good with the individuals and might have, you know, some intimidation or lack of experience or expertise with databases or more sophisticated, you know, management tracking systems. So having a user-friendly interface is important because it can be a whole new skill set for people to manage, and it's something that you all want to consider as you move towards more effective tracking systems.
Is anybody using Clinical Advisor?
You know, we talked to Bridget and Alice about that, and I think why don't we ask them to respond about their own system and Clinical Advisor.
So I've had numbers of conversations with other providers about Clinical Advisor, and the feedback that I've received is you don't own the data and you don't have the ability to run the reports and manipulate it and use it the way you would if you had your own system. The other thing is Clinical Advisor is an electronic health record. And so what they're caring about is not all the other things that we have to manage on the program about research dates and, you know, addresses, all the other things that we need to be able to do. Clinical Advisor is not going to be able to do that for you.
Yeah, it was never. Clinical Advisor does. You're running two businesses simultaneously and together, and one of those requires you to manage your research, and you've got a number of research, and that's not something that was ever built into any system like Clinical Advisor. So you really do have two different functions, and I think people say, well, a Clinical Advisor should be able to do that, and I'm not so sure that's necessarily correct. So,
Marty, this is Chris. If it makes anybody feel any better, even inside the Magellan world, PSH is a different component than anything else that we track in our integrated medical record system or in Clinical Advisor. And so we have our own database that we use to manage these applicants, and it is external. It's a separate unit than Clinical Advisor or IP. So that's not what you're absolutely right. IP or Clinical Advisor are electronic medical record systems. They are not designed for these types of services for maintenance, if you will, of service eligibility.
Right. So I think a takeaway is that while in a wonderful, perfect world, there's like one data management system that we can track everything in. That's really not the case. And it's not only just with this program. It's with a number of programs. And as a program, Alice, I appreciate what you were saying in terms of really wanting to have your hands on the data that you need to manage as well, and not having to rely on someone else to be giving you the information that you need to be able to work with in a more timely way.
Yeah, and Chris, you're absolutely right. There's no way to contemplate all of these, and I think as we go more and more towards managing in you're going to be in the health world and you're going to be in the housing world, and both of those have they're just not going to ever be the same requirements. So this is great though, and I think what you're able to do here is show, how you're reducing the amount of time by better managing, looking at the same stuff over and over and over again. So gives you more time to put things in Clinical Advisor that you need to. Think about it that way.
Any other questions? Well, if there's no other questions, we said that this was going to last an hour, so I know we're coming up on that. Michelle, I'll briefly turn it over to you if you have any updates or anything that you need to share with the group.
Sorry I was late dealing with some stuff. I do not have anything new. We are, as we all know, moving to the October 9th date. I did send the invites out for the roundtable. So if you haven't replied to that yet, please do so we can get a good head count.
This is Chris. I missed the first few minutes, so I'm not sure who all's on the call from the providers. Do we have most of the providers on this call, the PSH providers?
Why don't we do, it's a great point, why don't we do a roll call? So Alice, why don't we start with you?
This is Alice and the team leaders from NoAID.
Hi, this is Ricky, Administrator with Alternative Living.
And the team leaders right here as well as Ada.
Jermaine Smith, Volunteers of America.
This is Joy and Tawana and Lyda McMillan with VOA GBR in the Lake Charles office.
This is Laura with Star Corporation, New Orleans and Baton Rouge offices.
Okay, Region 4 VOA.
Marty, I think I'm representing them today. This is Joy.
Okay, gotcha. Okay, anyone from Hart? Nina?
Lionel and Tree from Florida Parishes.
Okay.
Yeah, we had Nina on the call. Nina, are you on mute?
It says Nina has self-muted herself.
Okay. Okay, and RHD? Don't hear anyone. And so we got VOA, Alternatives, and START. Okay. I think everyone but RHD is on, Chris.
Okay, well, what I was going to do is I was just going to let you guys know, I don't have specific dates yet, but a little bit, just as a heads up, the week of September the 23rd, we are going to do a couple of remote location trainings. We're going to bring our show to you guys. We're going to go to Metairie, and we're looking for a central location in Metairie where we can invite all of the New Orleans and then any Baton Rouge providers that want to come to a central point, and we will do 2 half-day trainings in 1 day related to eligibility and claims and clinical advisor, and a refresher for those of you who already had it, and maybe if you've got new staff that haven't had any of it. So we're going to do that the week of 9/23, and then what we're going to do is go to Lafayette, and hopefully we can get the folks from Lafayette and Lake Charles to all come to Lafayette, and we can do the same thing there, also the week of 9/23. We haven't set firm dates yet. We're trying to find specific locations, and we'll nail down those dates as quickly as we can and get that out to you. But the intent of those 2 training times is to bring everybody in together, do an informational session, be able to walk through eligibility, walk through what MagellanProvider.com, walk through claims, walk through billing, all of that sort of stuff. We'll do it twice in a day so that you can rotate staff through, or if you can come to one and you can't come to the other or whatever. We'll go to Lafayette and then do the same thing. And then if that doesn't capture everybody, if there's somebody that just can't, then we'll figure out another opportunity. But we were really hoping to get everybody condensed, if you will, so that we can come to you and address those issues. And the more people we can get in the room that have the same issues, then one of you will bring up questions that others have, and so we can resolve as many of those as we can. Then when we go live on 10/9, because we didn't, and we said it that week because we didn't want to do it sooner than that, because then that would be this will be 2 weeks in advance. We didn't want to do 3 or 4 weeks in advance, because then that's a long time to not be using this information before we go live, and then try to remember it on the day that we go live. So we're going to do that the week of 9/23. That's our target at this moment in time. And then the week that we go live, starting on 10/9, our expectation is that there are still going to be questions. There are still going to be issues. Claims aren't going to file right. Those things are going to happen. So what we will do is have our team available, not just the PSH team, but also claims and provider relations, et cetera, available to go out to each of your locations. You will be scheduled with a time before we ever go live where you know on that day we're coming to your home to help you walk through whatever process issues you're having, what you're seeing or not seeing in MagellanProvider.com, what you're seeing or not able to see in Clinical Advisor, and what claims issues aren't processing, so that our staff will be on site to help you with those things for a half a day or whatever it is that it takes. We'll schedule those in advance so that you'll know what day we're going to be there, either 10/11 or the following week, so that we don't want to wait until you have an issue. We want to actually be preemptive and get out in front of it, help you resolve those things so that we don't have 2 or 3 months worth of, well, this still isn't working. Can I get somebody to come out here and help me? So I didn't want to usurp the meeting time. I just want to give you that little bit of a heads up. We'll get with you specifically on the follow-up dates in your own locations, but then we'll also, as quickly as we can, hopefully next week, give you a specific date on the training dates that we're going to be bringing to you, one in Metairie or in that location, in that locale, one in Lafayette. And if there's somebody that just can't make one of those, as soon as we get you those dates, if you say we simply can't do that, then we'll figure out a plan B. But we did want to try and condense them as much as possible to put as many of you in the room as possible at the same time, comfortably, of course, so that you can learn from each other, so that we can learn from your shared experiences. So those of you who have done some of these issues through CPST or ACT in other settings other than PSH, we can pull on your experience, et cetera. So I hope that helps to clarify a little bit of kind of what's coming down the pipeline. Any questions on any of that?
Chris, this is Laura from START. Just to clarify, this would be open to all staff, right? Not just management staff to attend?
We will leave it up to you to tell us who you're going to send, the people who actually are going to be doing eligibility determinations, the authorizations, the claims processing, those people that need to know how to do those things, we certainly want you to bring those that there may be some capacity limitations,
Okay,
but outside
sure.
of that, we want you to be able to bring the people that are going to need to get this information firsthand.
Got it. Looking forward to it. Thanks.
Will that just be for 1915I clients, or will it be for all PSH clients?
Now, our intention is to walk through all of the systems, the eligibility, everything that we know we want you to know about all the different client types at that moment in time. It won't just be strictly about 1959.
So let me clarify. For you all, for the waivers through OAAS and OCDD, there's going to be separate trainings for those from those program offices as we work towards moving you all into being providers for them.
Right. At this point in time, those waivers aren't even finalized yet. So when we
So what will be billing?
And to clarify one thing, Bridget mentioned this earlier today, and we need to continue to reinforce this, is that when somebody's leaving a nursing facility, they may or may not have long-term care services for the long term, no pun intended again. So as you begin this program and as you get more familiar with it, you will understand that having people go through the process that Chris is describing for you, but that people's type of reimbursement might change after they're in the program, and you need to be aware of that. And that's something that you need to be talking, I think, more about, so you will understand that as you go forward. It's not likely that somebody's on a DD waiver would change in the future, but it's much more likely on the long-term care side. It could even happen in reverse. People's age, they change. Their qualifications, their eligibilities change. So I think that one of the things to keep in mind as you go forward is that while people might look like they're in a certain box, that you're going to need to work with Magellan, and Magellan will be working with the other offices and with you through their care managers, just because eligibility may always change. So is that
Which funding will have to be billed through Magellan? If you're saying that the OAAS and OCDD waivers are not approved yet?
No, that's
Or would it be because
clear on that. I think what Chris was saying is they're going to cover the Magellan services. The OAAS waivers and OCDD waivers, that is approved. We are going to start, before we start transitioning folks, you all have to be certified as providers. So they're working on that training and are looking to do that either end of September or beginning of October. The first step in this is going to be that we have 150 people who are currently in the program who are receiving long-term care waivers through OAAS, and they need to transition from the LTPC waiver to the community choice waiver. We're going to do those 50 at a time. So the plan will be 50 for September, 50 for October, 50 for November.
But so, it's also true, right, Michelle, that come October 9th, some of those people will be on CDBG only until they're transitioned over.
Right. Let me finish this. So, okay, so we're going to transfer them from the long-term care waiver, this is the first step, to the community choice waiver. At that point, you won't be billing them for that service yet. We need to get them from one waiver to the next. As we do those 50 a month, the smartest thing for us to do is to have you as the provider work with them to make their choice of a provider to do the switch. So we are going to talk about this at the roundtable, but just so you know it's coming, OAAS will be there to talk about that, what the process looks like for the team to help them make the choice and get all their paperwork in. So after the folks are switched over to the community choice waiver, The actual billing will start over January, February, and March. Because this is not a one-step process, it's a two.
Right, right. But again, I think it'll starting with the roundtable and then the work that Chris and his team will be working with you all the way through till the end of the year. It'll be very important to try to connect the dots between these different the different functionalities and the different requirements. But just to remember that the clients themselves, over time, things may change. So that's going to be an important feature. You're going to have, between, I'd say, the day you come to the roundtable and all the way through to the end of the year, it's going to be very important to pay particular attention to these immediate turnover issues while keeping your eye on the long term that as Magellan and the offices work together about doing this, they're going to continue to give you information. So what you may hear and what Michelle has said and Chris today, they will update that and update that and update that. I don't think it's going to be one discussion and it's over.
And I just want to be clear, we're going to guide you through all these processes. These are completely different processes from what you're doing with Magellan. So we're giving it to you in pieces, but we're going to assist you and do the trainings to make sure that this is as smooth as possible.
And Magellan has some functions with everybody. So that's another reason to keep your eye on the ball, is that not everybody is walled off. There's a connection here now between all of these various functions across the fund sources, in addition to qualifying individually, as Michelle is talking about, for the other fund sources.
So come October 9th, other than community development block grant funds, what other funding source will we be using? 1915I waiver? That's it? For just those clients who qualify for that?
1915I and CDBG will both be billed, right. CDBG
in
only.
The beginning, that's correct.
Right,
and
then, as Michelle said,
the waivers yet. We're going to get you to that point. In the
right.
beginning, day one, it's going to look like everybody's CDBG. Then we'll start pulling them off the people that you can bill Magellan for. The waivers will come later, but it is approved to happen.
Michelle, this is Bridget. In the beginning, we talked a lot about, with Ann, the freedom of choice form. Is that something that y'all made a decision on, or that through this instruction and meeting with Magellan that we'll learn more about?
For freedom of choice, for Act and Fact, you cannot have PPST and Act and Fact. Have people who are already in the program who currently have 2 CPST providers, that can happen with a coordinated effort. We have submitted to Medicaid the protocol that we're looking at using. We're just waiting for them to say that that works, and then we'll get with Magellan on that.
Okay. Thank you. And just for a business question about that decision, not to get into a big lengthy discussion, you said you submitted it to Medicaid. Just for our own business and knowledge, is there a possibility that as the housing support team we would possibly bill on just housing and they would do the other services, or is that something you can't mention now? I'm just wondering, because we need to look at if only certain units will be issued, let's say, for a housing situation or housing goals or services, we'll need to look at our numbers as well, because that might affect that.
Bridget, this is Ann.
Medicaid has that information right now. They're going to be making a decision about it today and getting back with us. Once that happens, we'll be coordinating with Magellan, and Magellan is going to be responsible for operationalizing that.
Okay. Thanks.
All right. If there's nothing else, it sounds like that's it. Michelle, anything else?
That'll do it.
Great. Thank you, everyone. Thanks again, Bridget and Alice.
Thanks, Bridget and Alice.
Thank you, Bridget and Alice. Okay.
Bye. Bye.
Thank you.